All right, good morning, everybody. So staying in the theme of our EMONC this week. So we're presenting about the same thing we are talking about all morning. So healthcare access to and coverage for patients with sickle cell disease, and especially thanks to the social heme committee. So basically today we're talking about the today will be about the component of access to healthcare and coverage for sickle cell patients, and of course, our beloved patient population. So the component of access to healthcare are we have to think about the acceptability of care. First, they have to accept that they have a disease. Then the availability of service to render the cure for or service they require to take care of their health, and of course the financial aspect of the healthcare. So acceptability definitely has a huge impact to do with cultural competency. So people tend to look for welcoming organization about the disease. They have to look, are they acceptable where they're reaching out for healthcare services. And of course, individuals have to understand when to seek for healthcare and medical treatment. And of course, availability of the service for them to find a good organization within their reach. And of course, that comes with the logistic part of it, part of the situation, appointment, hours of operation, and location. And the big part in our patient population here in Brooklyn, the financial availability, the indirect cost to healthcare, and of course, most of our patients have Medicaid, Medicare, and but they still think about the indirect cost to healthcare before they could reach out for any healthcare services. And that brings, especially when they have a chronic disease, that brings us to the sickle cell and sickle cell disease, sickle cell anemia to be precise. Just a quick outline. I won't spend much time on this slide. We all know what sickle cell is by now. So the background, obviously, immigrant community, people from Hispanic regions, non-Hispanic as well, Caribbean, Africans. Pathophysiology, we all know by now hemoglobin SS is the worst type of the sickle cell. And of course, you have VOC, the crisis, hypoxia, distress, cold weather. We tend to see more patients coming to the ED for VOC. And of course, the presentation, pain crisis, respiratory distress. We spoke about acute chest, pneumonia, whatever they have a pneumonia, we have to cover for cases as well. Dactylitis, that's very early on in a pediatric patient. Acute anemia, vascular necrosis of the bone infection, strokes. But to focus back on why we see this in our community, we tend to we have a high prevalence and high incidence rate of sickle cell disease in New York State, and that has to do with our immigrant communities coming from different part of the world, especially Caribbean, African, and South Asians, and Hispanic community as well. So this article looks at the incidence rate of sickle cell in New York State, comparing newborns of US-born mothers and foreign-born mothers as well. And basically, it just shows that one in every birth in New York State, we have about one in about 1,000 live births in the United States have sickle cell disease. And we tend to see this more in the non-Hispanic Black mothers, which account about 86% of sickle cell disease cases. And comparing that to our Hispanic mothers, about 12% case. So that's a huge, big difference. And looking further, the article further explained about the incidence of newborn in live birth in New York State. And with non-Hispanic mothers, we see one in like into 30 birth compared to Hispanic and non-Hispanic white mothers. And this says about newborns of foreign-born non-Hispanic mothers had a twofold higher incidence of sickle cell disease than those born to the U.S. non-Hispanic mother. And this value is very clinical significant. And that the New York population is very dense population full of like immigrant communities. And like I said earlier, so we tend to see more of these cases in our neighborhood compared to our population we see at Kings County and UHP. So with this dense population, of course, we expect to see more of like not enough resources going around to take care of all these patients in our community. So I just want to ask people in the audience, so which just determinant factors affect patients with sickle cell disease to access healthcare? Now, we shouldn't think about the medical aspect of them, coming to the hospital. It's what's keeping them come from the hospital for treatment. So, what would we think will affect them, like will impact the uh, availability and also in medical treatment to come to the hospital? I guess we all know what that is right now. So
How's it,
just go ahead and,
how's
oh,
it for
sorry.
access? I mean, if some patients don't have access to the Hemont clinic because of, say, they don't have transportation or they live too far away, and that right there, they can't even get into the system.
Definitely, yeah, that's one of the things actually that was brought up with my meeting with Dr. Mutu. It, being able to like have access to the sickle cell clinic because of appointment availability. But it's just that next factor that uh, I found that was like, the psychological health of being able to like accept that they have disease sometimes, and the awareness, the education literacy, and of course the income comes to play, geographical location, finding a safety net hospital around where they live to limit their transportation costs, and of course gender. That's when it comes to like being a female. Sometimes it does some society, some people from different background to seek medical attention, and of course age and language communication as well, which plays a big role in our ecosystem here in Brooklyn as well. Uh, people from other part of the countries, they can communicate in their desired language, and of course we try to use our translators a lot, but sometimes there's still that communication factor that counts into this seeing patient and talking to them in their own desired language. So looking at all these factors that kind of impact the access to healthcare, and that doesn't change anything with normal population. That is, agriculture, education, work environment, that can affect how they live in the community. But with sickle cell, it makes it even harder to like being able to like be among community and live well and make some good contributions to the society. So why is it essential to this population? Individuals seek medical care too late. Sometimes we have this population, they're used to the pain and they just said, oh, it will get better. So I've seen people with sickle cell, even back home, that they tend to say, oh, he's just going to pain right now. The pain won't get better anymore. And now that I've understand what they're going through, it just makes me think, looking back, saying, oh, so that person is going through a lot of pain. They should have seek medical attention than just waiting it out. And at that point, they go to become used to the pain and even tolerating a higher level of pain. So sickle cell patients, they have Medicaid. They tend to use it a lot, of course, with frequent visits And of course, they tend to take on lifelong medications. And with being a chronic disease, it tends to affect their employment opportunities as well, because they have to look at jobs. So, and some jobs, some positions cannot like accept them due to being able to take some time off from work due to pay crisis. And of course, organization wants to like run the company, so they would rather take someone that doesn't have sickle cell than deal with somebody calling out like every other week. So employment opportunity is very relevant, and it's very something that we should talk about when we see our patient in the ED. And one thing that I really found really interesting when I was doing my research was the Joe Biden administration. This statement from the website saying, living with sickle cell has meant putting the goals and plans of everyday life on hold because of chronic pain and serious health complications associated with it. And although the disease impacts people of all backgrounds, it disproportionately affects Black and Hispanic Americans. My administration has worked tirelessly to close these health disparities and help deliver care for sickle cell disease patients and their families, and we will continue to do so. So that shows that there's so many, they continue, they're kind of like putting the healthcare into their budget and making sure this population actually receive adequate healthcare. And the recent update found in New York State is that they, which is about 2 years ago, saying sickle cell can now only qualify for some services. Usually, before this update, the individuals would rather have to have like some other comorbidities to be able to take all these benefits, like home health aid, having some good services. But with this update, they'll be able to, let's say, just having a sickle cell qualifies the individual for a lot of benefits. And usually young pediatric patients qualify for this as well. And to manage comorbidity, to be able to like visit their primary physicians and also a monk clinic to reduce amount of being to reduce hospitalization and spending admitting times in a home as well. So one thing that I found also is how can we continue to do our part as ED physicians? Of course, when we see patient in the ED, we have to always consider the out-of-pocket costs in every decision we make, and also the education and awareness about the medical diseases. Some patient, of course, I'm sure we've all heard it about ED, that the patient took some ginger for a while and it wasn't working before they present. At that point, it has been like, long time. And I've seen patients in the ED telling me they don't have a disease or oh, I don't have that, but they definitely do. So education plays a big role as well. And of course, I said earlier, language barrier, the beliefs on the community as well plays a big role as well. And the biggest thing I've also noticed is undocumented immigrants. People come from different countries with different routes. So once they're in the ED, they kind of, even coming to the ED is like, going out of the shell. And when they're in ED, when they see like too many people walking about or seeing the hospital police going back and forth, they tend to believe that, oh, maybe they're reporting that they don't have papers. I've seen a patient walked out because she just came to the border and she left before medical treatment, actually. And that really got to me. Like, I was just told her, like, don't worry, you'll be fine. We know we are not part of that. But still, they tend to believe we may report them and going back to their country is not what they really want to do. So sickle cell patients sometimes new to the country, they don't know how to navigate the healthcare system. They're in pain. For them to come to the hospital and think about undocumented issues as well, that kind of makes it hard to treat this kind of patient as well. And we've seen, we continue to do our part in Kings County and UHP. We will continue to navigate for our patients because with the M&Ms we talked about this morning, with people, patients having acute chest, if there's a way we can prevent them coming to the ED in the first place, we should all try to continue to do our best and make sure we can limit these occurrences. Because if we can limit, if we can the right appropriate organizations, adequate follow-up, and adequate pain control at home, sometimes we will limit them coming to the hospital with a lot of infectious symptoms resulting in serious adverse effects. And with my meeting with Dr. Muto last week, one of the things he mentioned to me, of course, we talked about so many things about an hour, but the one thing he said to me was some patients will not come to his office, to his clinic in like 5 years, 6 years, 10 years. He told me a patient came to his office in 2013, then again 2024, which was like sometime last month. So he was just saying, the patient said, oh, I don't have any symptoms, so I don't have to come to your office. I don't have to come. So they came when they were having acute crisis. So he was trying to say, if we can try to limit, if we can try to like increase the follow-up, then we can try to limit the adverse effects. So the resources we have in the ED and the UHB, I believe we have that at the UHB as well, will be Dr. Mutu definitely at Kings County. He also said to me that we can actually connect this patient with social worker and they can link them with sickle cell clinic. And of course, I found like sickle cell thalassemia patient networks in Brooklyn here, and I'll try to like post that number as well. They tend to like create resources outside of the hospital for patients, be able to like have adequate follow-up and good resources. But definitely at Kings County, Dr. Mutu is our point of contact, and he's very, very on top of things. I've called him once in the ED, and he saw the patient within like 3 hours or 2 hours. The patient already received transfusion, and very, very nice doctor. Actually, I spoke with him, very, very nice guy too. So in putting this together, there's a case recently that I noticed or I saw. I didn't see the patient myself in the ED, but there was a 25-year-old male with sickle cell disease, hemoglobin SS type, came to the ED, new to our system. He has not been seen by any provider. I believe, looking at this name and looking at his age, my guess is he just came to the United States. So he has not been seen by anybody. There's no care everywhere on his chart. He came to the ED because he ran out of meds and usually give himself some injection at home for pain. So for him to come to the ED, that means the pain is very, very like out of control. So quickly reviewing his chart, he got some Toradol, Tylenol, then adequate pain control with some like opioids as well. Patient was admitted to medicine because all the workup was negative for ACS or infectious symptoms. It's just VOC. Sickle cell team saw the patient in-house, increased the dose of hydroxyurea that was started by the medicine team to about 1,000 milligrams. By day 5, the patient was discharged. It's a good case actually. It was in-house. It didn't get even sicker in-house. It didn't develop acute chest in-house. The patient was actually, the pain was manageable, it was improved, the pain improved, and the medicine team actually make sure the patient has a good follow-up with Dr. Mutu in clinic. And that's a key thing with Dr. Mutu. That's what he's trying to say. We should make sure patients have good follow-up in the clinic and close follow-up to be precise. So we don't see them when they're getting worse, and that will also help him manage the chronic diseases as well. So this is a good case. And I know sometimes we focus on the bad outcomes, but sometimes we should always focus on the good outcomes as well. This is a very good case, and the patient was in and out within 4 days. So the take-home point about this sickle cell access to healthcare will be we've talked about today, it's a privilege to people that have actually have access to healthcare. I know some of us, we can just we can just think, oh, I have this, let me just call my friend to prescribe this for me, then we're done. But people that don't have it, it's hard on them. And definitely access to healthcare includes availability of service, financial affordability and acceptability of care. And of course, we have to focus on it. We have to be cognizant of the factors affecting this population, the epidemiological societal factors. And of course, we have to make sure the new patient that come to the system, we have to tell them about the government assistance program. Sometimes they're not aware about all this Medicaid and Medicare to help them have enough access to healthcare. And of course, uh, access to healthcare for our population, we have to make sure they have enough. It improves their life, makes them healthy lifestyle. And these limitations can be mitigated by the healthcare providers, that is us in the ED, navigating their care in the right direction and organization to follow them up and reduce severe outcomes. So these are my references, and I believe we all know more about sickle cell today. Thank you. I will take any questions.
Just a comment. Great job, Bastu. I think it was an excellent presentation on sickle cell disease and all of the kind of social factors that go into it. I mean, chronic disease that affects people at a young age is really difficult in general. And I mean, socioeconomic factors play a huge healthcare factor in terms of their outcome and their progress and how they can access care. And sickle cell specifically comes with such a stigma. And so appreciate you kind of highlighting that.